afternoon once again. Nurses in the house, please wave your hand, please. Please wave your hand. Oh, great, beautiful. Please clap for yourself, please. Our ward managers, I salute you all. I have a question for you. Do you people work as a team in your hospitals? Do you work as a team or no? This is for the doctors. I hope we are working as a team because we do that in our hospital here, CardioCare. So if you are doing that in your hospital, please clap for yourself. We must always work as a team. Thank you. So this afternoon, we'll be discussing the role of nurses in sudden cardiac death prevention. You spend more time with our patients more than us. Most times you are shifts, be with the patients. And most of these things that we are going to discuss, we have been doing them. This topic is just to refresh our memories. What is sudden cardiac death? It's coined from two words, sudden and cardiac. Why sudden implies that death occurred unexpectedly. The sequence of events that leads to this death occur within a short time and usually probably 1 hour before death. And it's generally assumed that the patient was, unquote, in stable condition before the sudden and this later event. So we all know why it is termed cardiac. It implies that the primary pathology occurred in the heart. So coming to define sudden death is a sudden and unexpected cardiac arrest that occurs in people who appear to be apparently in good health. It is generally assumed that majority of these victims die of ventricular arrhythmias, usually in the form of VF, and the remaining sudden cardiac death victims either die of bradyarrhythmia or pump failure. We have discussed heart failure yesterday. We just discussed acute coronary syndrome a few hours ago. So the ventricular fibrillation, what does it do? It results in a rapid and complete loss of blood circulation. So the heart is not getting effective circulation, and as a result, this can result in irreversible organ damage and then leading to death, cardiac arrest. So we can see this is one of the ECG that can lead the guest to sudden cardiac death. We have seen this before. Okay. So our role and the role of everybody. Primary prevention of sudden cardiac death requires identification of future sudden death victims before the first arrhythmia episode. And the correct identification of this victim is very, very important. And being our nurse managers, it's important to identify this before, as quickly as possible, then escalate in real time. So the good thing about this is that effective defibrillation via an external or ICD that we do during the cardiac support, CPR and advanced cardiac life support that we still learn about shortly. So what are the risk factors? I'm sure some of us are dealing with neonatal pediatrician here. So the risk factor for sudden cardiac death include the age between birth and first 6 months, and then 45 and 74 years. Gender, sudden cardiac death is frequent in men than women. So who can tell me why it's frequent in men? We must answer, men in the house, why is sudden cardiac death frequent in men? Stress of life. Well, a lot of studies have shown that it's more frequent in men. One, women, the protective hormones, the progesterone and estrogen. Then in men, they do more of smoking and all. not those cardiovascular risk behaviors that they engage in and all. So that is why it's... Then existing cardiovascular disease, heart failure patients, coronary artery disease patients, then I will be using it interchangeably. Then patients with history of family history of sudden death or sudden cardiac arrest. So these individuals, they have 1.5 to 1.8 fold increase risk in sudden death. And I'm sure we take history in our hospital. We don't leave history taken to doctors alone. If we have clapped, you should clap too. Small clacking, you can do small clacking for us too. For the fact that we have clapped, you should not say, they've clapped. No, so we are a team. We should always work as a team. There's some history that we may forget to elicit from guests, but you can help us to get that. So family history is very key to elicit from individual with sudden cardiac death. So this is just to show us why a guest can develop VT, can see infarction there, cardiomyopathy, all causing myocardial damage. Then because of the myocardial damage, scar formation, fibrosis, hypertrophy, all these they are homogeneous substrates that can predispose to VT then VF. As much as possible, we don't want our guests, our patients, to end up like that. Our role is to save lives. So in any way we can prevent death, that's what we want to do. Okay, so what are these changes associated with this electrical disease? So Dr. Iseko mentioned long QT and short QT. I don't want to bug us, but he mentioned that, who can remind us what he talked about the QT interval? Yes, let's make it an interactive session. QT interval. We just finished ECG session now. Should be about half of the RR interval. So if there is long QT, it can predispose a guest to sudden cardiac death. Then short QT. And in those people, there are some drugs you avoid. So history taking is key. So don't leave history taking to us. We are working as a team. Okay, then the Brugada syndrome, the Wolff-Parkinson-White, the homogenic right ventricular cardiomyopathy. So all these ones are causes of sudden cardiac death. So this can be gotten through history taking also. Okay, so there are currently 4 major identified etiologies where we see ventricular fibrillation, the setting of acute cardiac ischemia, ventricular arrhythmia in patients with heart failure or valvular heart disease. So patients with heart failure or valvular heart disease, they are patients at risk of sudden cardiac death. So they need close monitoring. So sometimes when we say that, monitor vital signs closely, 15 minutes is not to measure, is not to monitor vital sign for 15 minutes, then multiply by 4. No, we will not multiply by 4. So we must measure it 15 minutes. So there are reasons for that. So ventricular arrhythmia in patients with inherited homogenic disease and then drug-induced proarrhythmia. Okay, other risk factors for sudden cardiac death include hypertrophic cardiomyopathy. During my residency days, we saw one boy with this hypertrophic cardiomyopathy. It was my Oga Dr. Oj. So when he saw it, he now sent for the siblings. Lo and behold, all of them. Okay. The Brugada syndrome, long QT, I mentioned this. Okay, so what are the signs? These signs, you may be the first person to pick it. It may be you, it may be anybody, but for guests with risk factors that we mentioned about, especially those one with heart failure that are on close monitoring. Okay, so when we see some alarm signs in them, okay, maybe the guest, you come to this bedside of the guest, okay, you register with the guest, then a few minutes he wasn't responding. Okay, you know that something is fishy. So signs, near fainting episode, loss of consciousness, lack of response to stimuli, and ceasing to breathe, among others. Okay, so when we patients on admission, well, this patients on admission, as I said earlier, close monitoring. So when we say close monitoring, as in close monitoring must be done, and should be checking them because we don't want them to develop VF. They have come to the hospital to be saved. We should not add to their problems. Okay, so if a nearby defibrillator is not available, we do CPR if we notice that maybe loss of consciousness and all. We start this. You know what we discussed yesterday? Dr. Eseko was using one name like that. I was using Mr. Chinedu. Mr. Chinedu, how are you? Are you okay? Are you okay? So we perform CPR as appropriate. And then it's good to know that survivors of sudden cardiac death should have ICD for prevention of subsequent cardiac arrest. Then family screening is advisable. So what do we look for? What do we look for? Both inpatients and outpatients. Both inpatients and outpatients, but more importantly on inpatients. Okay, identifying high-risk patients is very key. Like 2 weeks ago, we admitted a guest with MI under close monitoring. So, cardiovascular disease, patients with a history of heart disease, hypertension or cardiac arrhythmias. So, somebody with previous history of cardiac arrhythmia now on admission is not somebody we not just said, okay, we are checking vital signs, 15 minutes multiplied by 4. No. So, sometimes we might say, okay, ICU admission. Then Dr. Eseko said, poor man ICU. One nurse, one patient, one other person. Okay, previous cardiac events. Patients who have experienced previous cardiac events such as MI and cardiac arrest, talked about this. So recognizing warning signs. So when you notice all these things, that's when to act. Escalate. Call. Chest pain or discomfort. Somebody who is not complaining of chest pain before and now start complaining of chest pain. And you know, every chest pain, ECG must be done. So we don't fold our hands and say, yeah, chest pain. Oh, it's ulcer. No. Chest pain or discomfort, sudden, severe or persistent chest pain or discomfort. Shortness of breath. Dizziness or lightheadedness. Palpitation. Somebody apparently well. Let's say complain of palpitation. So it's time to act. Ward managers, hello. So ceasing to breathe. Okay. So what to do? We need to act quickly. Call for emergency assistance. So activate the emergency response system or call the local emergency number. This for abroad. Yeah. Call the doctor on call. Everybody that must be present must be called. Escalate in real time. So we assess the patient's airway, the breathing and circulation. And then we start CPR as we have learned yesterday. And then you will be shocked that this your intervention will bring these patients back to life. At least I can boldly say that at CardioCare we have up to 95% success rates of our basic life support and advanced cardiac life support. Please, a round of applause for us, please. Okay, so providing the emergency care, defibrillation, we saw the AED yesterday, then some patient can have the ICD in them. Then the issue of medication administration, I want to give it to our nurse manager. They are doing well. They are doing well. Please, a round of applause for you again. So, administration of medication as prescribed, they are doing well, exceptionally well. We administer the medication at the appropriate time. 10 o'clock is 10 o'clock. 12 o'clock, Abiyam Adelai. Then, or provide oxygen therapy as needed. Cardiac monitoring. Continuous monitoring of the patient. Okay. So what about the post-event care? Maybe the event happened while the patient was on the ward. Then the patient can be transferred to ICU. You yourself can even write that the patient can be transferred to ICU. Well, after escalating appropriately, you can make decision. This patient, I think he needs ICU care. Doctor, what do you think? I think this patient needs ICU care. Okay. Then continuous monitoring of the patients. Then patient education. If it's a patient with family history, so we encourage other family members to screen. If the patient has risk factor for the cardiac arrest, sudden cardiac death, heart failure, Compliance with medication, regular clinic visits, and all. And then lifestyle modification, alcohol cessation, smoking cessation, and all. I believe that our nurses, they are very good in their counseling. Well done, Master and SARS. Okay, so prevention strategies. Encourage risk factors, modification, smoking cessation, encourage regular checkup, and then cardiac rehabilitation. So in the history, it's important to assess the patient cardiovascular history, previous cardiac events, hypertension, hyperlipidemia, family history I've said earlier, current medication. You know, I told us that the long QT and short QT medication, some medication can actually should be avoided in them. So I said the patient current medication, including beta blockers, anti-arrhythmic drugs, anticoagulants, monitor the vital signs closely, and continuously monitoring the patient cardiac rhythm is very important. Education and support. Educate the patient and their family on the importance of follow-up and lifestyle modification, family support, provide emotional support, and all. Okay, so thank you so much. Any question? Question? I know this is what we have been doing just to refresh our memories. Any question? Okay, thank you all.